took my mask off only because I don't think you're going to understand a word I say with it on, and we are a good distance from you. But if anyone's uncomfortable, wants me to put it back on, please raise your hand and I will. Okay. I have been vaccinated. All right. There have been a couple things happening in our office that I want you to know. First of all, you'll notice that my sidekick, Bob, is not here. My husband had the nerve to retire in September. And the firm is now Breslin, Murphy, and Roberts. Besides myself, we have Christopher Murphy, my daughter, Christina Roberts, and another attorney has just joined us. She's not a new attorney, but she'll be new to us. She's coming from a trust and estate background, and that's Mary Kay Anthony. And you may have seen our announcements, and I'm thrilled that we were able to lasso her away from more lucrative areas, but she finds working with us to be more worthwhile. So with that, I'm going to turn it over to Dr. Kat, as we call her. My daughter, who's the neuropsychologist and is now in practice in this area. So
most people have never heard of neuropsychology, so I thought it would be helpful if I explain what I do. So neuropsychology in general is the study of brain functions. And then my specialty is in studying how the brain ages and in understanding all of the conditions that can affect the brain as we get older. So that's why I'm here to help talk about some of these things and what dementia is and what we can do when it hits our family. So in terms of an outline for today, there's a few things that it would be helpful for us to go over, just so we're all speaking the same language. So what is normal aging? What is dementia? What are the types of dementia? And even how do we distinguish between these types of dementia? Also, what do we do? How can we treat dementia? And what are the things that we need to do to plan for the future and protect ourselves and our loved ones? So first, what is normal aging? So normal age-related changes are the expected changes that we see as our brains continue to develop over the course of our lives, even into older adulthood. So typical things that happen as we get older is our speed slows down a little bit, our working memory, that ability to manipulate something in your mind, that becomes a little harder, and our brains are just as efficient than they were previously. Yes. So processing speed and working memory, which is that ability to manipulate something in your mind, and cognitive efficiency, so just how efficient our brains are at doing tasks. Now, if we think of our thinking skills as being on a continuum, we have normal age-related changes on one end of that continuum, and we have dementia on the other end of the continuum, but there's this category in the middle called mild cognitive impairment. And mild cognitive impairment is when there's thinking that are quantifiable in testing, and it's not impacting our day-to-day life too much. It doesn't impair our ability to take care of ourselves. Now, dementia is when those cognitive changes actually start to impact our ability to manage daily affairs. Now, some of these reversible causes are nutritional deficiencies. So as we get older, sometimes our bodies don't absorb the nutrients that they need from food in the same way. So that's something that is easily reversible with a vitamin supplement. things like sleep apnea. Who's heard of what sleep apnea is? That's the thought of wearing a CPAP machine. Right. That's something all of us think about and think, oh, I don't want to deal with that. But that is something that actually impacts our memory and improves when we treat it. Now, fortunately, they're coming up with a lot of different treatments for sleep apnea. So hopefully we'll have better and better treatments so we can treat the sleep apnea without having to wear the dreaded CPAP machine. But until then, it certainly is helpful to talk to the doctor if you're worried about sleep apnea, because that's something that can reverse memory changes. There are other things like infections, for example, urinary tract infections. That can really, really mess with our thinking abilities as we get older. And with an antibiotic. So these are all things that there's several it may not be a progressive condition, and it may be something that we can treat. And the sooner we treat those things, the better we will feel. Now, there are several causes of dementia, but dementia is really this umbrella term. It's the overarching term that just has to do with the level of impairment. So it does not talk about impairment. It's just recognizing that there's changes in our thinking. As I said, there are reversible causes that we want to rule out and treat and address. But then a number of the conditions that lead to dementia are what we call neurodegenerative. So they meaning that they progress, they will continue to get worse. The most common type is Alzheimer's disease. It is really causes something like the rates range between like 60 and 75% of cases of dementia are related to Alzheimer's disease. But what is Alzheimer's disease? We know that from a symptom perspective, it can impact changes in our memory and our language. But on a cellular level, that we call it pathology of Alzheimer's, it has to do with how misfolded proteins accumulate in our brain. The ones related to Alzheimer's disease is amyloid beta and certain types of tau. And so these proteins accumulate in our brain, and this is what we think of as Alzheimer's. Now, why does that cause symptoms? It's related to the parts of the brain where those proteins accumulate. Now, that's different from a different other dementia that impacts our frontal lobes and our temporal lobes, where that is caused by a protein called TDP43, which is a type of that likes to accumulate in those parts of the brain. And that's different from Lewy body dementias or disease dementia, which is caused by the misfolded protein alpha-synuclein. Now, you'll see in the chart, there's one type of dementia called vascular dementia that has less to do with the misfolded proteins and more to do with the narrowing of the blood vessels in our brain. When that happens, our brain is just less efficient because it's not getting as much of the oxygen and nutrition that it needs from the blood. Now, as I said a little bit ago, Alzheimer's disease really accounts for about 2/3 of dementia cases. There's a little bit of debate as to whether vascular dementia or whether Lewy body dementia come next, because Lewy body dementias include both dementia with Lewy bodies and Parkinson's disease dementia, because they're related to the same misfolded protein in the brain. diagnosis early. So if you notice these changes, you really want to alert your medical professionals that these things are happening. And then the next question is, well, why? Don't we not have good treatments for these things? Why get diagnosed early? And this is important, A, because it may be one of those reversible conditions that I mentioned earlier. So certainly it's something that we can treat, and we want to do that. The next is because we actually know that if we get the diagnosis earlier, it allows all of the care providers to come together to support the person as a whole person rather than kind of keep things siloed. So this not only includes the patient, the person themselves, but their loved ones, primary care providers, sometimes neurologists or psychiatrists, so it allows everybody to come together. It also allows us to prioritize our goals. And I can't tell you how many people I've talked to where they get a diagnosis early and they say, you know what, and I'm going to retire early. Or, you know, we were going to wait to travel, do this big trip in 3 years. We're going to do it now. So it allows us to make these informed decisions about what we want for our lives. It also allows us to participate in research because the earlier we diagnose, most of the trials for research and treatment right now are happening in the earlier stages, but also it allows the person themselves to be involved in that decision about whether they want to participate or whether they would rather not. There's no right or wrong, but there's a lot of people I talk to who feel like, well, if it's happening and I can contribute in some way, then I want to participate in research. There's other people that are like, I'd rather not. I just want to spend my time, the time I have left living my life, and I'd rather not. Some big things that are really important is that the people I talk to that are in the earlier stages are more susceptible to scams. So this includes how many of us have gotten emails or phone calls that are clearly scams? And how many of us think these people are getting more sophisticated in their, I can't tell you, there was one 2 weeks ago, looked dead on for a package from UPS, and I get things from UPS, so I thought, oh yeah, I must have missed a package, and then I was like, there's a link, let me call, I don't like that, and I called and they said, yeah, it's a scam. But there was nothing obvious about it that would suggest that that was a scam. And so as these scammers are getting more and more sophisticated, and as our cognitive abilities start to become less efficient, we're more at risk of falling for these scams. And so being able to put things in place to help reduce that risk can help protect you and the hard-earned money that you worked for. Also, it's important to learn what type of dementia someone has in order to address it. Yeah, I'm going to cover that when I talk a little bit about treatments, because the different types of dementia have different treatments. Other things that it allows us to do, sometimes we need to adapt our homes to make them a little bit safer, whether it's putting grab bars in the shower or securing guns. That's less of an issue here than when I lived in Virginia, but certainly something to be mindful of, that sometimes there's things that we need to do to keep ourselves and everyone around us safe. Driving is a big thing. I talk to people a lot about driving and driving safety, but driving is a big responsibility, and certainly I can talk even in my own life. Had a loved one drive into a flower shop. Would have been really helpful if a medical professional had intervened or someone had intervened sooner. So we talk about this. I don't want to take someone's right to drive away, but if there's issues that are preventing them from being safe behind the wheel, whether it's reaction time or there's issues with visual spatial abilities. That's helpful to know so we can come up with a plan in place to help the person keep independence and autonomy while also keeping them safe. Also with early diagnosis, it really allows us to talk about both how do we help the family and the care providers understand what's happening, and how do we train everybody around? Because while medications can be great, they're not always the best answer. And sometimes having some understanding of what to expect over the course of someone's illness can be helpful in knowing how to respond, how to react, and how to help them. Also, it helps with medications because there are some medications that can lead to cognitive difficulties. Benadryl is one of the biggest culprits I see. That drug that's in Benadryl is also in all of those medications that have PM at the end of it, whether it's Tylenol PM or Advil PM. That medication, when we take it night after night, can really exacerbate our cognitive thinking. So that's something that for people who already are having some cognitive changes, well, there are other medications that we can use instead to help them sleep or to help with allergies. And so we want to try and do that as well. We also know that by getting all of the care providers on board, both in the home and the medical professionals around, it actually reduces hospitalizations. Hospitalizations can be really distressing for someone who's already having cognitive changes, who may not remember, especially if they're in an acute state where they're having an infection or something that's exacerbating their cognitive issues. So that can be really distressing where they're out of their home, they don't know what's happening, why there's other medical professionals around, maybe even in some instances why their loved one isn't there. So we want to try and limit those as much as we can. It also allows us to intervene from a mental health perspective. I told you I was a neuropsychologist, which means that my background is in psychology. And so understanding someone's mental health and the impact that mental health has, not just for the patient, but for the caregivers, is really important. This is actually one of the biggest predictors for quality of life as we get older and in dementia stages. So if we want to incorporate things like psychotherapy, peer mentoring, support groups can be wonderful. Also programs like this, these community-based programs that provide education as well as sometimes socialization or exercise, recreation, that can be really helpful as well.
One of the effects for many from COVID has been the isolation of people and the effect that has had or exacerbated the conditions for not just the person with dementia, but for the caregivers.
Yeah.
Not getting the help.
Yeah, absolutely. Especially, I know the Alzheimer's Association has a number of online groups. I refer to those, especially for people who have otherwise don't have access to community resources. Maybe they live in a more rural area. I refer to them all the time, or they just can't get out of the house because they're being the caregiver. So the online groups have been great. Absolutely.
The comment for those watching at a distance is just don't forget about the online support that are available. So if you can't get out or for various reasons, and it's very true, and they become much better. I mean, one of the good effects of COVID is learning how to communicate with each other, virtually.
Absolutely. for dementia. Some of them are modifiable, some of them are not. So things that are modifiable include things like smoking, diet, exercise. Things that are less modifiable are things like age. You know, we're all getting older every minute, whether we want to or not. Also, things like diabetes are risk factors. Prior history of stroke and head injuries are risk factors. Education is a risk factor. As I mentioned earlier, sleep apnea is a risk factor, as well as things like hypertension, high cholesterol, so high blood pressure, high cholesterol are also risk factors for developing dementia. So if you have those medical comorbidities, those medical conditions, working closely with your doctors to make sure that they're well managed can help minimize that risk. So what are the signs that we look for? Some of them are bigger signs, pretty obvious ones, where the person is wandering out of the house and getting lost. They're having trouble picking out their clothes. They're having trouble bathing, grooming, those types of things. Some of them are a little more subtle. Sleep changes, for example, can be a sign. Trouble following a recipe for some people. Some people it's just stress, especially we've all been there with the pandemic. The last 18 months, I'm sure we've all noticed some things, but for other people, following a recipe or forgetting to turn a burner off can be a sign. Forgetting one's personal history is often a sign that something is going on cognitively. So forgetting where you went to college, or how many children you have. Those are often can be bigger signs. I think one of the more stereotypical things we think about is when someone keeps repeating the same question. You know, that's one that we often see. Yeah. And often something that I hear from patients is not just the repeating, but they're repeating the more frequently. So the time in which they repeat, it gets shorter over time. So how do we evaluate for these different disorders and what type of disorder it is? Well, the only way to definitively know is on autopsy, which is often too late it's not really helpful at that point in time. But there are better ways and ways in which we're very effective. Some of them have to do with new advanced technologies and brain scans, like PET scans is a big fancy one that we've been seeing more and more of. But even an MRI scan can help us understand what is leading to it. It doesn't detect the specific misfolded protein, but we can often tell based on where in the brain it looks like the brain is shrinking. All of our brains start shrinking around the age of 30. I'm sorry to share that. It doesn't make any of us in this room very happy. So when we talk about the brain shrinking, we're often talking about, is it shrinking more than we would expect for someone's age, or are parts of the brain shrinking faster than other parts? And when that happens, that can often suggest a specific type of disease process. Other things that can be helpful, it's not super pleasant, but a lumbar puncture where they actually look at, well, what's happening in the cerebral spinal fluid? Can we detect more or less of these proteins than we would expect? And that can be helpful. And also what I do. So I look at cognitive functions, and we know that these different disease processes impact the brain differently. And so we can help by saying, well, it looks like this part of the brain was impacted, So based on this other information that we have, it's most likely due to this type of disease as opposed to this other type of disease. So these are all things that we can do. There is some talk about a possible blood test for Alzheimer's, which would be very exciting, but is not widely available as of yet. And then there are different treatment options, and the treatment options really vary based on the type of disease that it is. So this is why it's important to know, because how we treat Alzheimer's is not going to be the same as the same way we treat Parkinson's disease. It's not going to be the same way we treat a vascular dementia, and it's not going to be the same way that we treat frontotemporal dementia. So understanding what the disease process is helps us determine, is there a medication that would be helpful? And if there's not a medication, are there certain behaviors or personality changes or motor changes we may expect to see, and how can we intervene with those? So, for example, with frontotemporal dementia, the medications that we use in Alzheimer's disease are not effective. And so in frontotemporal dementia, we may use medications to help treat a symptom, but there's also a lot of behavioral changes that happen where we have to use behavioral interventions to help manage those. In Parkinson's disease, we all think of the motor, the tremor. There are actually brain surgeries procedures that they can do before someone hits a dementia stage that may help to reduce the tremor symptom. And then if they have less tremor, they may not need as much of a medication, which may mean they have less side effects from that medication. So that can be helpful. So what are some of the medications? Well, certainly we look at medications for mood. I mentioned I'm a psychologist. I am not a psychiatrist, which means I don't prescribe these. But the medications for mood can be help. It's one of the, as I mentioned, it's one of the best predictors of quality of life. There are a couple other medications for Alzheimer's that have been on the market since the 90s. These are ones that I am sure, have heard of. So these are Aricept and Namenda. These medications work. They are not disease modifying. They work by keeping chemicals in the brain longer. And so they don't actually have a huge impact on the type of testing that I do, but there was just a study, I forget if it was out of Sweden or Switzerland, where they actually found it helped people who took those medications were independent for longer and had lower rates of mortality. So they are not perfect, but they are very safe. The side effects tend to be pretty benign, and they've been around for a long time. Now, many of us have heard of this new medication. Aduhelm is the brand name. It came out in June. It got FDA approval back in June. But if you've been following it at all, you've noticed that there's been some controversy, to put it delicately, around it. So what's the big deal about it, right? What's the big deal with this medication? So this medication works by targeting that misfolded protein, that amyloid beta. So it targets that protein. And there were 2 clinical trials that were happening in the very early stages of the disease. So mild cognitive impairment and a mild dementia stage. And what happened with these clinical trials is they were halted because some patients started having an adverse reaction to the medication. But then other patients seemed to be doing better on it. And so they did what's called a post hoc analysis, meaning they went back and they reviewed the data after the fact. They pulled some of the patients out, which is always a questionable in a drug study, and they reran their data. And they found that for the patients on the higher dose of the drug, there was a small statistical effect. We do not know if that means there's any real world effect, but they found there was a small statistical effect. Now, what are the problems? Well, I mentioned the drug trials, they were stopped because a number of patients were having an adverse reaction. So about a third of the patients had either brain swelling or something called, the acronym is called ARIA, which is amyloid-related imaging abnormalities. So a fancy way of saying the brain started bleeding. So about a third of patients were having these pretty big side effects. So understandably, the medical community is going, wait a second, so you're telling me I can prescribe this drug. About a third of these patients could potentially have this side effect, and we don't actually know if there's any real world benefit to these medications. And they felt like this process was rushed, and the FDA gave approval for reasons that had less to do with them really feeling like that it was going to be helpful for patients and more to do with the potential for profiting off of a medication. The medication is expensive, and Medicare will cover 80% of the medication. The remaining 20% is about $11,000 a year. Yeah. Now, if you have a supplementary insurance, they may pick it up, they may not, but that also likely means premiums are going to go up because they're going to be covering this medication. So this is why a lot of medical professionals, especially ones who work in the field of dementia, they're saying we more than anybody want to help our patients, but we're just not sure that this is the best way to do it. And so you've seen a number of big memory centers have come out and said, we won't prescribe it. So. I have no idea. I don't know. I was just listening to a podcast and it was talking about they were doing their own analysis, and essentially there should be 1 0 off the end of that based on their approximation. So I don't know why AARP thought it was a good deal. I know there was some question as to whether the Alzheimer's Association had been involved in some of the funding, and they had really pushed for the approval for the drug. There are people who have ALS, so Lou Gehrig's disease, there are drugs that have had better outcomes where those drugs have not been approved. And so the ALS community is up in arms, like, what do you mean our drugs aren't getting approved when this one is? Because our drugs have better outcomes. So it's been pretty contentious. Now, that being said, there are some other drugs that are in the pipeline that potentially will be more interesting. So stay tuned. There's a few that do look exciting. So hopefully we will have, next time I'm here, hopefully I'll be able to talk about another drug that will be less controversial.
Notice, and I'm not a medical professional, is when I work with clients and the various types of dementia. I mean, when it's frontal lobe, generally the individual may become more aggressive or more behaviors, such as suddenly, spending all the money at the racetrack. Maybe that's not the best example. One more extreme changes in mood and the potential violence that they and then with Alzheimer's itself, there's a whole gamut, I think understanding what form of dementia an individual has, then will better prepare the family to take steps. And if they're needing to find placement, to make sure it is the right placement. Good friends of ours, their grandfather had Lewy bodies, which person can have outbursts. And they ended up placing him in a memory care facility, or alleged memory care, and they couldn't deal with his outbursts. And now they're suing him for having struck an employee. So you just be careful all the way through and seek the help. So I'm going to switch now. Before I switch to some of the legal items, do you have questions yet for yeah.
Our old family doctors are not prepared for this kind of problem.
That actually the patient I saw this morning, that's what literally verbatim what the doctor said.
Trying to get them to say, I don't think we really should drive it on. It's just old age. Don't worry about it. That doesn't work.
Yep.
I think that's one of the emphasis.
Yeah.
We're fortunate that in this area, there are extremely good medical systems that we can turn to. I mean, University of Penn, I mean, they're the leaders along with Jefferson Medical. So we have, excellent resources, and they're on top of, the new medicines and other forms of treatment. And so, it's good. It's fortunate. When Kathy was at the University of Virginia Hospital, the area they covered was over 300 miles or so. And so many locations were rural, and people really couldn't make the trip into the hospital setting. So they tried to work with the general practitioners and the family to train them better so they could better treat. And then, and we're beginning to see some of that here. But I also get a little leery when I see the big medical systems and wonder, but that's another. You're not here to hear me go on. So, yes.
One of the words I think you put was cognitive.
Yes.
All right, my friend was 66 when he died from Alzheimer's dementia. And he got so competitive, he was beating his wife up. So she had to go to the cops.
Yeah.
But there was a special dementia hospital in Wilmington, just for, it's like a nursing home. You put him in there, nice to visit him, chance for you to die.
When someone's combative, it's very difficult to find appropriate placement. So many of your long-term facilities and all, they don't want to touch them. They see the word combative.
If they think there's any risk, they're leery about taking them.
But when,
But there is this kind of more.
yeah,
And then you're speaking about, I call them, old-focused doctors. I'm talking about the generics. My mother, she was 95. I took her to Dr. Winkler. He was that special to be an old-focused doctor. That's your crucial. And Winkler, I didn't pay the R. So I know a lot of people know, but we still got a parent that I think you should take them. Dementia or having to active to remove patient crisis programs. They take art classes, and I think that
It's the best treatment is exercise. It's so good. I tell my patients this all the time.
it's so good that pharmaceutical companies study why, because they want to put it in a pill and sell it to people, right? Like it's that, yeah, most of us would. Sign me up, right? But it's really good for a lot of reasons. It increases our blood flow, it helps us sleep better, it helps us to generate new neurons, even in the face of Alzheimer's disease. But as you were saying, Farah, it's also important to stay socially engaged and to stay cognitively stimulated. And people ask me all the time, well, what should I do? Should I buy Lumosity or do? What research tells us is do the things you enjoy doing. If you do what you enjoy doing, the outcomes are the same regardless of whether it's something you spend a lot of money for or whether it's something you enjoy. So do the things you like to do. You'll have better outcomes.
When they say exercise, you have to be running marathons, walking.
Or even yoga, tai chi, stretching. Quite frankly, anytime you get into the water, I mean, there was just an article the other day and the headline was something to the effect of, it's not a pill to be young forever, but it comes pretty darn close. And, water aerobics, you get the resistance, so you're getting the strength training, you get an aerobic workout, and you don't get impact on your joints. So it's really, if you like the water, that's a really great option. Yeah. So this is a great
The question is, what is the effect of general anesthesia on the mind?
So this is a great question, and there's not as a straightforward an answer as we would like. So one of the most interesting studies that I've come across is one that talks about the different types of general anesthesia and how they impact our sleep cycles. So we know at different points during sleep, there's different things that happen in our brain, including clearing the gunk out. So there are certain types of anesthesia that have less of an impact on our sleep. And we're not talking just while we're under anesthesia, we're talking about for several weeks after the surgery. So that's the most interesting one I've come across. Yeah, so basically the anesthesias hijack our sleep stages, impact how long we spend in the different sleep cycles, which impacts how efficient our brains can clear the garbage out. Not from what I found. I will say that's just what I've seen in research. It doesn't mean there's not an effect. I will say, if someone's under general anesthesia and their heart stops, it's gonna have some problems, right? That's a different issue.
Make sure between you, tell the anesthesiologist. Say to me, Tom, can you hear me? I was in anesthesia, getting ready to get cut open. I'm laying there, and the anesthesiologist says, well, he should be asleep by now. The surgeon says, all right, give me the scalpel. And I'm laying there, wait a minute. I hear this guy say, give me the scalpel. I'm not asleep. I jumped off the table. I had IDs, why? I jumped off the table. I had no clothes on. I jumped off the table. And that's reaction. I'm groggy. I could see the exit sign. No clothes. I'm running down the hall. They had to go chase me. And I told the doctor, why don't you ask your patient, are you asleep? Because if you answer, he knows you're not.
Jeff, good morning.
I'm not saying there's no reactions. I'm saying, does it kill brain cells? That was the question. And that's where I haven't come across research to suggest that. But I have come across, if you're not sleeping well, it's going to mess with your mind. I don't disagree with you. It increases delirium and things like that. But does it itself kill the brain cells?
Well, you have capacity. What should you be doing? Definitely put your affairs in order. Now, for capacity, we mean do you understand what is going on, what the documents are going to do. With a will, do you understand the value of your assets? Do you know what you want done with those after you die? And who is to take charge? Who's going to be your executor? With your power of attorney, that's when you're alive. Who is going to help you? Who's going to help pay those bills? Who will make healthcare decisions for you? Have you made it known what your wishes are? You know, if you go in for surgery and things don't go well, and you know they're saying you're not going to regain consciousness, does the family know what your wishes are? You know, so when Kathy said to get the diagnosis early, you want to do it definitely while you have the capacity to address what is to happen now and in the future. I have seen too many cases over the last few years where, and it's usually one child or one family member will be taking advantage of the situation and pushing their parent to make changes to the estate plan to their benefit. Under the guise of, oh, Dad, don't you want to make sure there's no taxes? You don't want everything going to the government, so give it to me now. You know, so you want to set things in place while you understand and at least assure as much as possible that those wishes will get carried out. I think it's also good to make sure with your financial institutions, especially like your brokerage account, that you have what they call a trusted advisor named, so that in the event your financial person has a question, something doesn't seem right. You know, let's say I call our broker up and say, Andy, I want you to sell everything we have and go give it to charity. He would have authority to call Kathy as our trusted advisor and say, oh, is there something happening to your mom? I mean, he won't necessarily say what I'm up to because that's confidential, but he can at least say, is something going on? You know, is there somebody in the wings who is trying to scam them? You know, and stop, you know, me from, you know, giving something to someone who says I won the Canadian lottery, or one of my grandchildren is in prison on the Canadian border, and things. The stories that they come up with get better and better. I also want to make sure that if you stop paying your bills, like your real estate taxes or your homeowner's insurance, that there is a safeguard to make sure that doesn't happen. I mean, you don't want your health insurance to lapse, your secondary insurance, or your life insurance to lapse now because a premium doesn't get paid. So you act when you can. There are a number of resources available now for persons we mentioned earlier to become active or get to know the caregiver support programs. in your areas, whether it's through the Alzheimer's Associations or Parkinson's. I had a client whose spouse was diagnosed with a really rare form of dementia. I had never heard of it before. And they actually had found a national online support group. There were only something like 200 cases in the whole United States. It was that rare. And I one of those that, and she really found them. Also, you want to start to get to know what are the programs out there that can help financially should you begin to exhaust your assets for care. And, you know, I handed out or had available the Elderlaw handbook with the 2021 page for figures, because the handbook was in 2020 and it's the 2021 update. But I want to stress there is a Medicaid program to help pay for in-home help, and we call that the aging waiver program. There is an income limit, and as of now, it's $2,382 gross income per month. With a married couple, they only look at the income of the spouse who needs help. They don't look at the other one's income. So if your gross income is below that, and then they look at your resources, and for husband and wife, there are a number of resources which are exempt. So I implore you to reach out to COSA to inquire. And aside from the waiver program, there is the state funded program. It's from the lottery money. So if your income is above that 2,382, then they're going to look at the state funded program to see what help you would be entitled to. There is also the family caregiver program, which is actually now run by Senior Community Services. COSA receives the money, but then they contract with SCS, and the program coordinator is Diane Twizzler, and her phone number is 484-540-4373. And what they do with the caregiver support program, there is a monthly allowance. It's only $500 a month, okay? But that $500 can help pay for, you want to clarify, John? Thank you. And my notes say 600, and I'm so stuck. Uh-oh, Kathy's gonna have me tested because I didn't adjust. Thank you. Yes. But the monthly reimbursement 600, and also the changes this summertime make it more available without getting to the nitty-gritty, so that Senior Community Services can find someone eligible, where in the past there were more limitations. It does have a reimbursement one time for a home modification, so stair lifts or a ramp or what have you, up to $5,000. And even if you don't qualify for the monthly amount, and it's a reimbursement, okay, they assign a counselor to you who, again, we were talking about your support groups, but this is one-on-one to reach out and see how you're doing, bring you up to date on changes, can in some cases become like your best friend. And I've had families helped by the caregiver support program for over 30 years, and it has made a difference to them. It also provides for the grandparents who are looking out after the grandchildren. and you're not here because of that, but I want to know it's just broader than taking care of a spouse or a parent or someone else in the household. So I sort of ran through the benefit programs because I know we will do a whole program by itself, but I just wanted to remind you that you want to find out what is available and always check into it because it is being updated. Congress right now is looking at providing more help to families to keep their loved one at home. So I'm semi-optimistic that things will get better in that regard. We'll see. So, questions? Thank you. Yes.